Hi guys, let's see about acute kidney injury. Acute kidney injury, also previously known as acute renal failure, is the rapid decline in renal function over hours to days, resulting in ACF expansion, uremia, hyperkalemia, and acidosis. We have the KDIGO classification. For stage 1, the urine output is less than 0.5 ml per kg per hour for more than 6 hours, or the creatinine level is 1.5 to 1.9 times more than the baseline. KDIGO 2 is less than 0.5 ml per kg per hour for more than 12 hours, or the creatinine level is increased more than 2 times the baseline. KDIGO 3 is less than 0.3 ml per kg per hour for 24 hours, or anuria, which is less than 100 ml per day for more than 12 hours, and or the creatinine value raised more than 3 times the baseline. Causes, we can divide it as pre-renal, post-renal, or renal. Pre-renal is the most common cause for acute renal injury. We have volume depletion. Mainly the intravascular volume is depleted, as in hemorrhage, vomiting, cirrhosis, diarrhea, or in decreased cardiac output. Systemic vasodilation, as in sepsis and other infections. Renal vasoconstriction, as in hepatorenal syndrome and hypercalcemia. Also in abdominal compression syndrome, where the intra-abdominal pressure rises to 20 millimeters of mercury. The treatment for pre-renal failure is IV fluids, and if there is some other cause, we should treat that, like sepsis. Post-renal cause could be due to calculi or prostate enlargement, bladder neoplasm. Here in ultrasound, we can see the stones, or either we can see dilatation of the urinary system. Renal causes, we can have acute tubular necrosis or acute interstitial nephritis. In acute tubular necrosis, it can be due to ischemia or toxins, which can be endogenous or exogenous. We have 3 stages in acute tubular necrosis. First is the initiation phase, where there is tubular injury causing solutes to leak in the acute interstitial nephritis is a T4 cell mediated hypersensitivity reaction to drugs like beta-lactams, rifampicin, and allopurinol. The patient can have skin rashes, and in the kidney we can see eosinophil, and the treatment is steroids. Pre-renal and acute tubular necrosis, we can have osmolarity. Urinary osmolarity is normal in pre-renal, whereas decreased in ATN. Urine microscopy shows muddy brown epithelial cells in ATN. The most significant investigation is fractional excretion of sodium, which is the fraction of sodium excreted by the fraction of creatinine excreted. It is less than 1% in pre-renal and more than 2% in acute tubular necrosis. Treatment for acute tubular necrosis, we should remove the offending agent, and we can, as we saw earlier, we can have complications like volume overload, acidosis, hyperphosphatemia, hypocalcemia, uremia, and hyperkalemia, which should be treated accordingly.